Lovely. Welcome everybody here in Tallaght University Hospital and online to this next lecture in our series, a joint lecture series for the Academic Primary Care Centre here between Trinity College Dublin and An Chosán. So I'm going to first let Imelda Hanratty from An Chosán introduce the session from the point of view of An Chosán and introduce us to the space. And then we'll introduce our speaker today, Maeve Lowery, and get going from there.
Thank you, Noel. My name is Imelda Hanratty, and I'm from An Chosán Education Centre in Tallaght. And it's a pleasure to be here today to be able to share in the experience of coming to Trinity lecture space. It's really good. So I coordinate a group in An Chosán called University of the Third Age, and our members are here with us today. So it's great to be able to see great facilities that are in Tallaght. So usually in An Chosán we start any of our courses with a little small reflection, just time to reflect. So I'm just going to ring the bells and do a very short positive reading. So the reading today comes from a book called The Complete Pocket Positives. A positive thinker does not refuse to recognize the negative. He refuses to dwell on it. Positive thinking is a form of thought which habitually looks for the best results from the worst conditions. Thank you very much. And I'll hand it back over to Noel now. Thank you.
So as per the holding slide, you can see there our title for today, Cancer Diagnosis Then and Now. And our speaker for today is Maeve Lowery. Maybe really well positioned to speak to this, as well as being Professor of Translational Cancer Medicine at Trinity. She's a consultant oncologist at James's, but has specific expertise in diagnostics and indeed chairs the Cancer Molecular Diagnostics Advisory Group of our National Cancer Control Programme. Her own medical specialty is in gastrointestinal malignancies, and she does lots of research to guide effective treatment in that, including using molecular methods to understand the biology of those cancers. So without further ado, Maeve.
Thank you, Noel. Thank you, Imelda, for the invitation and for the lovely reading. And thank you, Lena, for setting up the meeting. I'm delighted to be here today to talk about cancer and cancer diagnosis. And I thought the reading positioned us well, hopefully, for the talk, because the idea of focusing on the positives, looking to the future and looking hopefully at the constructive things we can do against the worst or the difficult or challenging conditions. That's sort of integral to the practice of oncology, isn't it? Always looking forward. And I'm going to give you a brief overview of, I suppose, from a national perspective and a more global perspective, the challenges we face in terms of dealing with cancer. And I'll look forward as to what we hope the next decade and beyond will hold in terms of new treatments, be those immunotherapies, more focused targeted therapies, or the new type of cell-based therapies, and just really explain what those are and the hope that they hold for improving outcomes for our patients suffering from cancer. So cancer is not a new condition, right? We're dealing with cancer as human beings for millennia. First ever description that's documented of a cancer diagnosis dates from almost 3,000 years BC. And it's from an ancient scroll, papyrus scroll, found in Egypt. And it depicted the picture of a female, a lady, who had had a breast cancer on the left breast. And it was allegedly removed with a fire drill. I don't know what that is, but that is not what we do today. And the accompanying hieroglyphics said about this condition that there is no treatment. That's 3,000 years BC. So even at that time, it was recognized by humankind that cancer is a serious condition and it's a serious challenge for us. And at that time, the tools were not there to better understand anything beyond the human impact and the medical implications or potential suffering associated with it. And then even the term cancer has also been with us for millennia. The term cancer means, I think, crab, and I'm not a scholar of those languages, but the actual word cancer came from Hippocrates. And Hippocrates, as you know, was one of the original doctors and philosophers and influenced hugely our medical practice even nowadays. And in fact, coining the word cancer, it was because on feeling a tumor or a cancer, it felt hard, like the shell of a crab. And when you observed it on the skin, you could see that there was kind of tethering or whirling around it that looked like the legs of a crab. And so it was termed cancer, and that term has stuck with us for the subsequent millennia. And Hippocrates, if you look back at those original descriptions that he had of patients who were suffering from cancer and his recommendations as to how we deal with it, he was actually the first proponent of treating people like individuals, like assessing a person on an individual basis and tailoring what you do to manage that patient according to their individual needs. And in fact, he advocated strongly for the principles of supportive care, managing symptoms and reducing symptom burden from a cancer, and interestingly, for communication with relatives, that dealing with and explaining things to the family of the person was just as important as treating the patient themselves. And those principles, I think, still hold true over subsequent millennia. Now, he did also say that cancer was caused by blocked black bile, and he was wrong about that. So that is not something that is held true. We know much better now what the causes of cancer are. And those differ according to where in the world you are located. It's important to remember these are population level reasons, right? Not individual reasons. And I'll come back to that in a moment. So cancer is caused by many things, and it's usually not caused by any one thing, but usually it's multifactorial things. So many, many causes that influence one's risk of getting cancer over a lifetime. And we never quite know how much one exposure might dial up or one intervention might dial down an individual's risk of developing cancer at some point in the future. But there's some obvious things. We know that cigarette smoking causes cancer or is associated with an increased cancer risk, to say that more accurately. Also, we know that our diet can influence our risk of cancer, both positively and negatively. Radiation exposure, be that ionizing radiation, radon gas in our homes, or a UV light from the sun, we know that that is also associated with increased cancer risk. And there was a whole generation of men and women who were subjected to occupational exposure to what we call carcinogens or cancer-causing compounds that thankfully we're more aware of now, or at least rules around occupational health in the workplace have minimized exposure to these and newer versions of these. But things like asbestos, where a lot of construction workers perhaps would have been exposed to decades ago, that resulted in the development of a rare cancer lining the lung called a mesothelioma, which is almost directly associated with exposure to that very toxic compound. And so there were some very tragic stories of generations of workers in specific areas who eventually, decades after they had worked there, developed very hard to treat cancers. So that's really why occupational health is still so important in minimizing exposure in the workplace to cancer-causing situations, environments, and compounds. And then there's a whole area of infections, and we're only really beginning to understand now the influence of many different infections on medical conditions overall. But there's been some very well-established connections between viral infections in particular and development of cancers. And that's things like HPV, human papillomavirus, which is associated with cervical cancer. And thankfully, we now have a vaccine against that. Hepatitis B and C, which can be associated with primary liver cancer, and Epstein-Barr virus, associated particularly in Africa with cancers of the nasopharynx. And of course, those exposures can vary according to where in the world you live. So we always, in the Western world, if you like, or in Europe and the US and Canada, we look at cancer through a narrow lens in terms of what our own exposure as a population might be to these cancer-causing things. But if you live in Thailand, for example, exposure to liver fluke is a big problem, and that can lead to liver cancers. And so the one's exposure depends, and on a global level, a global burden of cancer, the different types of cancer we see across different continents varies hugely based on the risk factors that that population is exposed to. And it also can vary based on their genetic background. So we know that also certain cancers can be associated with their predisposition to cancer. And that's when we find a family where perhaps there are multiple family members who have a cancer diagnosis. And in that situation, we look to see, could there be an abnormality within a gene that can be passed down through several generations that can predispose or increase the risk of a person getting a particular cancer. And the most well-known one of these is the BRCA gene, the BRCA1 or BRCA2. Most people know that Angelina Jolie had the BRCA gene, and that's associated with breast cancer. Everybody knows that. Ovarian cancer, some people know that. But not so commonly known is that that gene is also associated with prostate cancer in men and even pancreatic cancer in men and in women. And so awareness of these syndromes are important so that we can intervene and both initiate preventative measures in those families and also cancer reducing strategies for patients along with early diagnostic interventions. And there also are some families whereby we see many cancer diagnoses, but we can't really explain it. And that's the unknown that we have yet to discover. Maybe genes we haven't tested yet, maybe areas of genes we haven't tested yet. And it's important that with those families that we carefully, on the research side, study to find out what the influencing factor might be that's causing cancer in that family. And many breakthroughs, if you like, in the area of cancer research have come from the generosity of families who have a history of cancer and have provided perhaps blood samples and information about their family that have helped us to discover new insights into what causes cancer. But I think it's important when we look at a slide like this to take a step back, because cancer is also bad luck. And all of these things add up to perhaps an increased risk of a certain kind of cancer. But really, at the end of the day, when an individual gets cancer, it's not their fault. Nobody gets cancer because of something that they did. And I think sometimes we're too quick to take these population level observations of things that modify our risk of cancer and almost use it to point a finger and say, that maybe one caused their cancer by something that they did, that they didn't do something perfectly. Their diet was not perfect. Their weight was not perfect. They smoked 20 years ago. But it's important to separate population health measures and things that we can do as an individual, as a community, as a country, globally to improve our health, and separate that from an individual's assessment that they caused their own cancer. And I say that very specifically because I see it a lot in the clinic, that people interpret this information and that the cancer is their fault. Many people live happy and unhealthy lives and never get cancer. Many people live happy and very healthy lives and do get cancer. And so I think we do have to be careful in the language we use around this and in the educational measures we use as a community and in community interventions to take this information and to focus on the positive. How do we take this information and lower our community risk of cancer, lower our national risk of cancer, improve outcomes as a nation for everybody? Not so much about individuals and what causes an individual's cancer, but taking all these many things that can add up to causing cancer, and then perhaps see in a positive way how we can influence that. I'm conscious of my in-person audience, cancer incidence does increase with age. That's just the facts. You know, we know that we're more prone to developing cancers as we age, and that's to do with how cells repair themselves and how they sometimes don't repair themselves so well as we get older. It's not a guarantee, it's just something that we see, that cancer incidence increases as one gets older. And in fact, observing that, it's important that we take that information and see how, well, maybe if we see that there is a distribution of cancer across different ages, we should perhaps look to see what people with different ages require that might be different in their cancer treatment or approach or preventative or screening or treatment measures. And there's an emerging field called oncogeriatrics, where you combine the expertise of a specialist in medicine for the elderly with the expertise of an oncologist or radiation oncologist or a surgeon. And together, you use the combination of assessment of medicine for the elderly with the cancer specialist assessment to design a treatment pathway that would be optimal for a person at their individual stage in life. And that becomes more important when we have patients who might be in their 90s, perhaps with the cancer diagnosis, in their late 80s, perhaps with the cancer diagnosis. It's important that we manage to combine expertise that looks at the person's stage in life with their cancer diagnosis and leverage the benefits of knowledge around both of those. But at the other end of the spectrum, we also know that there are a small number, but a real number of children diagnosed with cancer every year in Ireland. And they also require very specialized pediatric treatment pathways. And what's increasingly recognized, also by the National Cancer Control Programme, is that as those children hopefully survive their cancer and age into adolescence, as they become young adults, that they also require different interventions. So now we know that perhaps with heavy chemotherapy to a young child, we might hopefully cure them of that cancer. We must be mindful of the effect on them longer term, be that on fertility, be that on their heart, be that on the risk of other cancers later on in life. And so at work within Trinity and beyond and nationally is the development of pathways for adolescents and young adults, either newly diagnosed with cancer or who have survived a childhood cancer. And again, looking to individualize and assess what that patient might need, be that in the counseling area, in the rehabilitation area, or in preventing secondary complications of their cancer. And then in the middle, cancer is obviously less common when you're in your 30s or 40s, but actually there are certain cancers where we're seeing an increasing incidence in that age group that we don't really understand. And so if we look at cancer of the bowel, so colon cancer, the incidence of colon cancer is increasing fairly dramatically in the Western world in patients between the age of 35 and 50. And we don't really know why that is. The cancer that I treat, cancers of the esophagus and the stomach, we're also seeing an increase in that diagnosis in men under the age of 50. And certainly they're not people one could point at any lifestyle factor as expediting the risk of cancer or increasing it, but rather it's an unexplained phenomenon that we have observed both in our local practice in Ireland and also internationally. And so again, when one thinks of diagnosis at that stage in life, people need different things. And of course, it might be a different support system that's required if one has young children in primary school and has a mortgage to pay, than if one is already retired, perhaps, but has grown-up children available to support, and not different to a single person in their 20s, perhaps, who's facing a cancer diagnosis alone. And so I suppose what the future, I hope and think will hold, is that we begin to treat cancer and provide supportive networks around cancer treatment, diagnosis, screening, that is specific not just to the type of cancer, but to the stage of life that person is at. And that includes providing survivorship support for people who have had a cancer perhaps earlier on in life or even later in life, and how one supports someone after they've had surgery or radiation treatment or chemotherapy in the years that will hopefully follow, to make sure that those years are lived as healthily and as happily as possible. Because I suppose we've been reliant for a long time on chemotherapy or radiation treatment as our mainstays of cancer therapy, and they carry with them increasing risks of subsequent complications. And we're only really realizing the burden of that as we begin to measure and intervene. So cancer in Ireland, what do we face nationally? Well, it is a growing problem. We know that. Many of you here will have been touched personally or within your families by cancer. And we anticipate that the incidence, that's the number of new cancers diagnosed every year in Ireland, will likely double by 2040. It's increasing by about 3% a year in Ireland. And there's a couple of reasons for that. Partly is because our population is getting older, and partly we have an increase in certain risk factors. And it's also becoming a bit more complicated treating people with cancer, because we're looking to manage many complex medical conditions at the same time as the cancer. So be that a hepatitis infection at the same time as a liver cancer, or a heart condition at the same time as a breast cancer. We're trying to juggle lots of different things. So it's becoming more complicated as the years go on. But on the positive side, we also have an increase in the number of cancer survivors. And that means increase in people who have come through a cancer diagnosis, successfully treated, and who will be cancer-free, or those who are living well with the cancer on treatment or beyond treatment. And we focus on those patients as needing as much attention as new cancer diagnoses as well. I deliberately haven't put COVID into this slide because we could take the whole next hour to speak about the impact of COVID on cancer. And I'm not going to, because as soon as I make a slide and it's already out of date, but suffice to say, there's been a huge burden that's been borne by patients with cancer from the COVID pandemic. And I suppose in a sense, it's a little bit hidden. Some things we see reported in numbers in terms of delays in diagnoses, perhaps delays in accessing treatments or in scans or other things that we know patients with cancer need to be done immediately or expedited. But there's a hidden burden that we see on the cancer treatment wards, inpatient and outpatient, where the lack of visitors, not being able to have a family member or a friend come and advocate for you when you're having your treatment, or the difficulties in visitation rights for inpatients, so patients who have cancer in for treatment or perhaps in for control of symptoms, who are without their loved ones at time of great need. And at the height of the pandemic, we really saw, I suppose, the most suffering behind closed doors in that way. I think that is important to acknowledge that for the health of others, a lot of cancer patients did without visits and support, really to protect other people around them. And I think that's something that we need to make very clear, that people did that bravely, but also quietly. And that is something that's not really measured. We don't really have the figures on that, but we do have the observations. And that is, I think, a sad consequence. And I really hope that before too long, we will have our patients' families coming back to the chemotherapy day ward and back to the bedside, so our communication can improve and that people can advocate better for their family members. And I'm sure this will come up in the discussion subsequently, because I know it's a big issue for patients currently in cancer treatment. So cancer incidence is the type of cancers that we see. This won't surprise anybody. There's been certain changes. This is about a 40-year period covered by this graph. And I suppose all I would point out is that the reason the prostate cancer spikes here is because of an enthusiasm for screening for prostate cancer around that time, which was not subsequently borne out as being as valuable as one thought. And in lung cancer, you can see maybe a decrease in men, thankfully, to decreased rates of smoking, but a bit of a bump here in women because of increased rates in younger women smoking, and hopefully that's beginning to ease off as well. And then some cancers that are perhaps not as commonly spoken about, things like liver cancer perhaps, or thyroid cancer, seeing a little bit of an increase in those also, and we'll come to that a little later on. So what are we dealing with in terms of usual cancer diagnoses in men and women? What do we see most commonly? I suppose in men, it's prostate cancer of varying stages. Thankfully, the majority of cases in cancer that can be well treated. And in women, breast cancer, also usually one that's diagnosed relatively early, not always, but also two areas I think where there's been huge breakthroughs in terms of the cancer treatments we can offer patients, especially over the last decade in terms of new drugs and new treatment strategies. Lung cancer remains a problem, both for men and for women. Again, there's been a big breakthrough in terms of new treatment options for patients with lung cancers in particular, especially in the area of immunotherapies, which is very, very promising for the future. And colon cancer, also a very common cancer that we deal with. I suppose when we look to see what cancer's impact on survival in a more negative way, it's interesting to see that sometimes the cancers that we pay a little less attention to from a patient advocacy perspective kind of creep up the list as being perhaps a bigger problem than we give them credit for. So there are some much more rare, but more challenging to treat cancers that in fact are more likely to become to the forefront in terms of urgent need for improvements in better treatments for patients with those cancers over the next decade. And that's especially pancreas cancer, or liver cancers, or bile duct cancers. And we don't hear so much about those cancers, or even esophageal cancer, which I treat. And I suppose there's sort of an advocacy, and again, speaking perhaps more towards my own patients, for the cancers we speak about a little less, perhaps, if there's still, while these are rarer cancers, there's also a big need there for us to focus on those as researchers and as clinicians to work hard to improve outcomes across the board. But I suppose if we look over the last decade, I would say there's been an explosion of new treatments and new ways to treat really all of these cancers with few minor exceptions. And hopefully if that continues over the subsequent decade, we'll make really big inroads into these numbers and see a big, big improvement by 2030. So take that information and think, well, what can we do? So that's fine, but what on an individual level or a population level can we do? And there's fairly clear guidelines as to what all the major bodies, WHO, Association for Cancer Research, all of our advisory bodies, if you like, would tell us to do to reduce our risk of getting cancer. And again, I would make it clear that these are population level or recommendations for an individual. If one doesn't do this, it doesn't mean it's their fault that they got the cancer. But these are strategies we can all use to reduce our risk. None of us do it perfectly. But when you combine a little bit of each of these strategies, then good for our health overall and good for reducing cancer risk. So if I had to pick one, it would be not to smoke. And I think that's probably where we can draw the most clear correlations, acknowledging that giving up smoking is hard. That's one that is quite a clear correlation. That's usually number one in all these recommendations is smoking cessation. And that means supporting people in giving up smoking, smoking cessation programs, support, prescribing to help people succeed in giving up smoking. Maintaining a healthy weight. Well, you know, that's, if you go to any health talk, maintaining a healthy weight is going to be there, right? But from a cancer perspective, it's interesting because obesity, so clinical obesity, one's overweight in that particular measurement, or reaching criteria for that, it's associated with the increased risk of certain cancers. And it seems like that's to do with inflammation in the body, that obesity can cause some inflammation that helps the cancer cells perhaps sometimes to grow. So maintaining a healthy weight is an important part of risk reduction in cancer. Moving around, taking exercise, well, that, unfortunately, that seems to be at the cornerstone of all public health measures, isn't it? But it does help in reducing one's risk of getting cancer. And that actually, interestingly, is independent from maintaining a healthy weight. So exercise by itself is actually really important. And that's even if you don't maintain a healthy weight, but you do exercise, there's benefit in that. And it's interesting because it seems like exercise kind of resets something around that inflammation that helps our body to reduce the risk of cancer, perhaps empowers our immune systems to be stronger in fighting cancer. Eating well, there is a couple of specific recommendations around that. And that is around reducing our intake of red meat and specifically processed meats. So that is unfortunately rashers and sausages and smoked things that taste good and salted sorts of meats. And it's because those have a particular effect when eaten regularly at large volume, not the odd time, in terms of increasing the risk of cancers of the gut. And it's to do with sort of the cancer-causing compounds and their exposure to the lining of the stomach or the intestines as they go through. A plant-based diet, well, that's something that's really become very trendy in the last 5 years. And I suppose we're all struggling to manage to switch to legumes and beans and whole grains, but it does seem to be a really healthy thing to do. And again, that's to do with not just maintaining a healthy weight, but independently of maintaining a healthy weight, maintaining a more plant-based diet, even if not solely, but just increasing our intake of whole grains and of beans, of vegetables, and of fruit. That also reduces the risk of certain cancers, especially of the gastrointestinal tract. And so it does seem that even if you modify your diet to tilt it a bit more towards a few beans, vegetables, fruits on a regular basis, and a little away from the more heavily processed meats, that could have overall a benefit. Put it down on alcohol to within healthy limits, that makes sense. And there's associations with many cancers with alcohol excess. And eating less salt, that's more to do with, I think, more population health measures and the healthy weight side of things, along with the reducing sugar. So there's always a lot of confusion around how eating sugar could potentially fuel a cancer diagnosis. And a lot we don't know about cancer. So there's a lot of diets that are proposed perhaps about minimizing sugar and how that might fight cancer. And I would say, first of all, there's much things that we have yet to learn about how one's diet influences cancer. The hard facts we have are that in reducing the risk of getting cancer, processed meats, moving towards plant-based diet, the whole grains, adequate fiber, reducing alcohol, those are objectively things we've proven. The sugar intake really speaks more to maintaining a healthy weight. And so, of course, sugary things tend to be easy to get the calories in, and so can tend to cause the weight to increase. And that's the association so far that's been made between intake of sugary things and cancer, less so much the idea that sugar fuels a cancer. But certainly big areas of research are how a diet could be modified, both to reduce the risk of cancer, and then after one's diagnosed with cancer, optimal nutritional strategies for how we maintain healthiness throughout a cancer treatment and beyond. So I might switch for the second part of the talk to speak a little bit about our cancer treatments. And that's because my own area is in chemotherapy administration or cancer treatment, because I'm a medical oncologist. So my area is in systemic therapies or drug treatments for fighting cancer. So some patients who have a cancer that's planned to be removed by surgery require treatment to shrink it down, or patients who've had a cancer already removed at surgery and require treatment to reduce the risk of that cancer coming back. And then some patients in whom the cancer is established and surgery might not be an option, and we're looking to control the cancer with drugs. And that's where systemic treatment or treatment that travels throughout the whole body comes in. And I suppose what I'll mention a little bit here is how we have new tools at our disposal, which we didn't have even when I entered the field of oncology many years ago. So taking a step back, what are we treating when we give these drugs? We're treating cancer. Cancer is growth of cells. And if it's a cancer, it means those cells are not controlling themselves properly the way they should, and they can occasionally spread either nearby or elsewhere. And terminology that frequently can be confusing to patients and even to our medical students are, well, what's the grade and what's the stage? So when we're looking to make a treatment plan for a patient with a cancer diagnosis, we have to ask ourselves a few key questions to get the diagnosis correct. That's first of all, where did the cancer start from? So what's the primary site of the cancer? Then we look under the microscope at a biopsy and it tells us the grade. Well, as the pathologist tells me that. And they say, well, are they kind of fast growing, very slow growing, or somewhere in the middle? And they can put terminology around that that's formal, that tells us exactly that grade. And then stage means, well, has the cancer spread? And if so, where has it gone to? And that's the stage of the cancer. And that is, for best standards of care, always decided at a group meeting, what we call a multidisciplinary meeting, whereby there's at least 2 specialists of every kind present to go through every individual diagnosis, the history of the patient, their symptoms, their tests, their medical background. The pathologist who goes through the biopsy tells us the appearance, the grade, and the radiologist who reads the x-rays and CAT scans and MRIs that tells us what's the stage. And that's how we ideally decide on a treatment plan for a patient according to best international guidelines for treatment of the cancer diagnosis at that particular stage, personalized to that individual. And that's the gold standard of care for how every patient who has a new cancer diagnosis should have their treatment plan decided upon. And within Ireland, that is something that is mandated by the National Cancer Control Programme, that every patient with a new diagnosis would have that discussed in such a manner. And that helps us to make sure that we're using the expertise of our colleagues together collaboratively to decide on best treatments. And I suppose a lot of our treatments, the recommendations are going to be around chemotherapy treatment, radiation treatment, or surgery, or frequently nowadays, a combination of both or 3 in some sequence. And chemotherapy, it's just a broad name for drugs that fight cancer. That's all that chemotherapy means. And chemotherapy, they're drugs, around with us for many, many decades, many of which we've been using since the 1960s or 70s without too many changes. And they are drugs which stop cancer cells, ideally, from growing and from making more cells. Because cancer cells like to grow quicker than normal cells, chemotherapy affects them more. So chemotherapy just tries to stop cells replicating themselves and dividing and making more of themselves. But actually it stops all cells in your body from doing that. It affects everywhere in the body. it has more effect on cancer cells because they're trying to grow faster than normal cells. But most or all of the side effects of chemotherapy treatment happen because it's affecting the normal growth of normal cells in the body. Kind of an off-target effect, right? We're looking to affect the cancer cells particularly, but in doing so, we have this spillover effect onto the normal cells of the patient. And so that causes, for example, the common one, hair loss, not in every cancer type or every chemotype, but by affecting the hair follicles. It can cause low blood counts by affecting the bone marrow. It can cause nausea or sickness or diarrhea by affecting the lining of the gut or affecting the bowels. And these are, I suppose, things that we've come to manage with supportive care and accept, but ideally would like to do better. And I would say chemotherapy remains the cornerstone of how we treat cancers. You know, this is real still how we manage most of our patients who require those drug-based treatments for cancer. But over the last decade, there's been a shift away from developing more chemotherapy drugs and more towards developing smarter drugs, drugs that work in a different way or a smarter way to target the cancer cells preferentially rather than the patient's normal cells. And in doing so, we hope that we're going to minimize the amount of side effects that person has from their treatment and also develop a more effective treatment for their cancer. And how do we develop these drugs? Well, we do this by developing research programs around particular cancers to find out how we can do better in developing particular treatments for a cancer. And a lot of that involves, in Trinity in particular, using all those biopsy samples or samples taken at surgery to learn more about the cancer and to identify what drugs or types of drugs might work better. So as an example, if a patient were to have a cancerous tumor removed during surgery, we can take that or a piece of that and bring it over to the laboratory straight from the operating room. We can divide it up and we can grow it. So we can grow it in a dish, which looks for all the world like a saucer, or we can grow it more commonly in a three-dimensional structure, which mimics the tumor that's found in the human being, so that we can have a model of that cancer, like an avatar almost, in our laboratories, so we can develop new drugs and strategies for treatments around that and test them on these samples before we would test them in the human being. And this is really where a lot of the innovation and new strategies around cancer treatments have come from, this type of research. I put the mouse there, but we use mice less and less nowadays because, again, we're refining our techniques more towards these three-dimensional structures where we're growing the cancer cells more in a way that mimics much more what happens inside a person's body. And so by doing so, we can try new ways to treat it. And that's what translational research is. That's my post in Trinity. And there's lots of different laboratories within Trinity focused on different types of translational research. And really all it means is trying to transfer new understandings from the laboratory into new strategies for treating human beings, both in preventing cancer, in treating cancer, in early diagnosis in cancer. And we do that by taking samples with patients' permission of the cancer itself, of blood, and developing strategies within the laboratories to see how we can better improve the strategies that we have. And importantly, the translation or transfer part of it is taking those observations back into the clinic. So if we find something might work in the laboratory, we have to try and develop a clinical trial around that to test that in a person. And that's how we move forward the field. And that's where a lot of the developments I'll mention to you next have come from. So how can we do better? What does the future hold over the next decade? Well, there's two main areas. And if we're looking to see what might replace or complement chemotherapy over the next decade, it's going to be one of these two areas, more than likely, or a combination of both: immune treatments and targeted treatments or personalized treatments. So targeted therapy, that really just means that we have to find out what's making the cancer cells tick, what's really driving them forward, and try and block it. What instructions are helping that particular cell grow so fast, and how can we block it with a drug? And that comes from cancer genetics. And our ability to look into the genes of the cancer has improved a huge amount over the last decade. It's become much easier for us to find out all this information. And I suppose what we're looking to do is find out what particular gene is turned on or off in an individual cancer cell and develop a drug that might help block and prevent the spread or growth of that cancer. And that's the idea of targeted treatment. And so that's an area, I suppose, that initially, maybe 15 years ago, the first drugs began to show success, especially in lung cancer treatment, then subsequently in melanoma cancer treatment, skin cancer treatment, and then in colon cancer treatment. And now this approach, where you take a sample from the biopsy, you look at the genes, and you choose a drug based on that result, is now part of routine care of patients with those cancers. And a big field of research we want to drive forward is to expand that to other cancer types by improving our ability to find what genes matter and also developing better and newer drugs to target them. And the other area that I suppose is the most innovative one over the last even 5 years is immuno-oncology, or using our immune system to fight cancer. And this is a whole new concept. So ideally, if our immune system were working perfectly, we wouldn't get cancer at all, because our immune cells would recognize the cancer cells as being foreign and bad for us, and they would get rid of them before they had a chance to cause a cancer. And that doesn't happen, not all the time. And it doesn't happen for a reason. It doesn't happen because cancer cells are smart. And they put up something that's kind of like an invisibility cloak, if you like, which makes the immune cells kind of float right by them and not notice that they're there. They hide themselves from your own body's immune cells. And the new generation of immune treatments that have been developed don't actually work really at all on the cancer cells. Instead, they remove that invisibility cloak to allow the patient's own immune cells recognize the cancer cells as being foreign and activate to try and kill them. So in a way, it's kind of empowering the patient's own immune system to begin to fight cancer. And that strategy has shown success in certain cancers and a bit less so in others. And I suppose that's where we have to always come back to our research and to the laboratories and to figuring out an individual strategy for a cancer and for a patient, because it turns out that even though the strategy around it makes sense, it doesn't always work in practice. And the way we identified why that would be is by that type of translational research to see, well, what's different about cancers that respond to immunotherapy and those that don't. And it turns out when one has a cancer, we can divide them into sort of cold cancers, what we call them, or hot cancers. And what that means is that these hot tumors are ones that have a whole army of immune cells already carrying their equipment and ready to fight inside the tumor. So when you get a drug on board that's going to remove the invisibility cloak and let them recognize the enemy, they are primed to attack and treat the cancer. So in those situations, for example, melanoma cancers or kidney cancers frequently, the drug works well. Other cancers, when we take them to laboratory and we cut them up and we look and see what's inside, there's no army there, or the army that's there has got no weapons. So there's no immune cells inside there. Well, if they're not there, it doesn't matter if you activate them. If they don't have any weapons, they're not activated and able to fight, then the drugs won't work. And so that's helped us realize that if we're going to expand using these immune treatments beyond the cancers where we've already had success, we're going to have to figure out how to turn a cold cancer into a hot cancer. And that'll probably be with other drugs or radiation treatment or even perhaps surgeries. And so it's an example of how you have some success initially in some areas with a new treatment. Doesn't help everybody perhaps, so then we have to bring it back, refine our approach and try again. And that's really the cycle of how we make advances in cancer treatment. And that's how over the next decade, we'll probably see new combinations coming of perhaps both these new types of treatments together. But in routine clinical practice now, we would use a lot of these immunotherapy drugs in combination with even chemotherapy drugs. And lastly, I suppose the other area that many will have heard of over the last, especially the last 6 months, is the area of cell treatments. And this still astonishes me that we can do this. This is really, when you explain it to me, it still sounds somewhat futuristic, you know? So this is the idea of taking a patient's immune cells, collecting them in a bag, expanding them in a laboratory, so growing them, fooling them and changing them up, giving them weapons to recognize an individual patient's cancer as being foreign, so kind of supercharging them, and then giving them back to the patient. So taking the patient's own cells, if you like, expanding them into a big army training that army to recognize the patient cancer cells as being foreign, and then giving them back to the patient again to fight their cancer. That's quite amazing to me. And that has now become a standard treatment. And that treatment has been given in James's, I think, at least 3 to 4 times so far since December 2021. So we're now in Ireland routinely giving this treatment. And we're giving it at the moment only for the approved indication, which is in certain patients with hard to treat blood cancers. But I think and expect this type of approach is going to become one that we go to for many different types of cancers over the coming decade. And it still amazes me, the amount of, as you can imagine, expertise needed to do this safely for the patient, and work needed to make sure that you grow that army of cells perfectly and with the right attributes to fight the cancer. That obviously takes huge expertise. But the fact that we can do this, we can do it in Ireland, it's kind of astonishing. So there's huge hope there that with these new techniques, new treatments, always driving forward and looking to see, can the impossible actually be done, that there's hope for much improved outcomes in the future. I'm conscious of time, so I'm going to skip forward a little bit of things that I was going to look forward to, a little bit I want to discuss specific to Tallaght, because I wanted to mention this. So I mentioned all these new treatments, and new treatments come to patients with cancer usually through clinical trials. Clinical trials are how we evaluate new treatments. They help us to get newer treatments to patients quicker and help us to offer new options to patients who may have more limited ones. And clinical trials are essential to helping us build and deliver those treatments. And over the last 6 months, we have developed a collaborative group through Trinity, funded by the Health Research Board, which is the Trinity Academic Cancer Trials Group. And this is a collaborative group anchored by Trinity College as the academic partner, led by Ray McDermott from here in Tallaght, and Elizabeth Vandenberg from St. James's, and Petra Martin from the Midlands Regional Hospital in Tullamore. And we've come together to join forces and leverage the infrastructure at all sites to deliver a better and larger portfolio of clinical trials to our patients with cancer. So this is important because a lot of the time a cancer clinical trial might be available only in one site, maybe the oncologist at the other site doesn't quite know about it. But now by developing these types of networks and working with our national network in Cancer Trials Ireland, will hopefully improve the access of patients, no matter where they live, to cancer clinical trials. And then we'll be able to join together our own resources and infrastructure to expand and improve what we have to offer patients around cancer clinical trials. And lastly, to mention before I finish, and hopefully we can have a discussion or some questions around it, is to mention the Trinity St. James's Cancer Institute. And so this is, it is genuinely a national project, but it's focused on joining together of Trinity College, initially with St. James's Hospital. And this happened even before I joined the group, way back about 10 years ago. The work towards joining together the clinical care part and the research part and education part began to happen. And there was a lot of work done in trying to figure out how best we can integrate research and education into developing best care pathways for patients. And this was a formal accreditation process. Now, accreditation has meaning, especially in the hospital world, because it means that someone flies in from abroad and looks at everything that you're doing. And we had to formalize a lot of what we were doing. We had to list what we were doing and evaluate, and made us look at what we were doing and see how we could do it better and how we can still do it better over the coming decade. And so in 2020, we were formally accredited by this European board, which designates cancer institutes. At the moment, we're the only accredited cancer centre in Ireland, and hopefully more will follow. And what this really allows us to have is international benchmarking, meaning we're not comparing ourselves to best in Dublin or best in Ireland, it's best in Europe. And the standards that we have to meet are set there. Not that we've met them all already, it's about a process of continuous improvement. What we're doing is being, I guess, open about how we can improve both research, education, clinical care, and importantly, drive forward that idea of innovating in the lab, pushing it forward and bringing new treatments and strategies to patients, observing what's happening with our patients and trying to do better. And so that's an exciting development. And I suppose what we're trying to do is, like I say, integrate the science with the care. And overall, influence the cancer patient's outcome, not just in James's or in Tallaght or in Dublin, but in Ireland. And hopefully through the good research of my excellent colleagues in the laboratories in Trinity and combining that with those treating patients in clinical trials, improve outcomes for patients on a wider scale. So I know I've gone on for almost 50 minutes, so I think I'll take a break there and see if there are any questions.